Good evening, everyone. I'd like to welcome you to our webinar that we're presenting tonight. And firstly, I'll begin by doing the acknowledgement of country. The QNMU recognises and respects the Aboriginal and Torres Strait Islander peoples of the lands upon which we undertake our work to promote and defend the interests and values of members. I would like to acknowledge the traditional owners and custodians who have cared for the country or countries on which we meet today for thousands of years, their elders past and present, as well as any Aboriginal and/or Torres Strait Islander people who are here today. Next, I'll just be reading out the QNMU Statement of Safety and Respect. The QNMU is committed to ensuring all its gatherings, including meetings, functions, and events, are free from all forms of harassment, discrimination, and racism. Attendees have the right to be safe and respected, and we ask that all attendees act in accordance with these values. If you have any concerns, please raise them with the convener of the meeting, function, or event. So I'd like to introduce myself. I'm Sarah McLeish and I work for the QNMU as an organiser for the Princess Alexandra Hospital. And in my time as an organiser, I've worked with numerous groups of members to assist them to escalate their concerns around occupational violence and ensure their safety in their workplaces. So that's why I'm so excited tonight to introduce CJ Catalan, who is going to speak to us about all the amazing work she has done in this space. CJ is a clinical research officer at the Princess Alexandra Hospital's Emergency Department and a lecturer in the School of Nursing, Midwifery and Social Work, Faculty of Health and Behavioural Sciences at the University of Queensland. Tonight, she's joining us to talk about occupational violence risk assessments and how doing these can be an integral part of empowering us to identify and intervene with occupational violence acts before they occur. CJ's presentation is going to take approximately 40 minutes, and after which we will have 15 minutes for questions and answers. Can I just ask for anyone whose name on the screen may not be the name they registered with, if you could change your screen name to the name you registered with. This is so that we can ensure that you receive your CPD points for this evening. So everyone, please give CJ a warm welcome.
Hello, good evening. How's everyone going? I hope you've come to the right talk. So just checking that you've come about for occupational violence risk assessments, and even if you didn't, please stay. I thought to begin, I will introduce myself. As Sarah mentioned, my name is CJ. Oh, look, I'm so happy in that photo. My name is CJ. I'm a research officer at the PA Hospital in the emergency department, and I would like to declare my position in terms of presenting that I present as an advocate for nurses and having a safer workplace. And if you are interested in connecting with me, please feel free to follow me on Twitter, or I am on Instagram trying to disseminate research, particularly nursing research. So let's connect. And before I begin as well, I would like to acknowledge three main organizations who have enabled me to do this work. So the Health Innovation Investment and Research Office in Queensland Health, who have funded this research, the work that I'm about to show you. Metro South Health and the University of Queensland School of Nursing, Midwifery and Social Work. Now, when we talk about risk assessments, I'd like you to think about the risk assessment tools that you use every day. If you're using it properly, as this picture depicts, the idea of risk assessment is picking up red flags. Would you agree? And also trying to control situations that precipitate bad events. The idea of occupational violence risk assessment is pretty much the same. That's occupational violence risk assessment, in this case, is used to pick up static and dynamic red flags or risk factors for occupational violence. Now, I'm just going to sort of also give a different take on risk assessment, and I do like to use the assault cycle as a theory to try and contextualize where risk assessments work. So the reason why I use is the assault cycle to simplify and explain the risk assessment is that the assault cycle, it categorizes the journey of OV into 5 phases. So the first one, you obviously have a triggering event. Phase 2 is the escalation. Phase 3 is the crisis, which is the event that we're trying to prevent. And there's a recovery phase, which there's still a really good possibility that they can go back to the crisis phase. And then phase 5, which is back to baseline. Now, where risk assessment fits is in the escalation phase. So, and the reason why this is that in the escalation phase, this is our fight or flight phase, that where usually the behaviors of concern are obvious to us. And that's when we use the risk assessment to then explore, okay, what's triggering, what's causing these behaviors of concerns. And so essentially our role as nurses is work with patients to find out what's triggering the escalation and how we can help them calm. So that's the best way of using risk assessment tools in occupational violence. So the tool that I'm going to be talking to you about is what we call QuadPro. So it's the Queensland Occupational Violence Patient Risk Assessment Tool. I named it Queensland as a nod to the organization that helped support this work and also where it was developed as well. Now, we actually developed and validated this tool to make it simple, quick, and easy to assess for violence risk factors, particularly in emergency departments. So as you have there on your screen, the QuadPro prompts you to assess for 3 risk factors. You have your aggression history, behavioral concerns, and clinical presentation of concern. And with it is you have some qualifying characteristics and what would constitute, for example, as an aggression history. And the level of response for each risk factor is a yes or a no. And what we then do is we score them according to the number of yeses or according to the number of risk factors, which is 0. So they get a low risk of occupational violence, moderate, 1, they get moderate, and 2 to 3 is high. Now, this tool is validated and it's been published on the Creative Commons license, so you can use it. You don't have to pay to use it, as long as you attribute the authors that develop it. So let's put some sort of science behind it. So if people have an aggression history alone, we found in our research that they were 9 times more likely to perpetrate occupational violence than those who did not. So in terms of behavioral concerns, they were 13.6 times more likely. And if they had concerns with their clinical presentation, then there was 7.1 times more likely. Now, in terms of using the risk ratings low, moderate, high, we found that what this area under the curve 0.77 means is we can translate that to using the tool, we have 77% chance of discriminating between violent and non-violent patients. So in essence, using the tool performs better compared to when using your clinical judgments that can vary over time and would also depend between people's experiences as well. So this is where tools come in handy as well too. Now, I'd like to show off a little bit on how we actually use the tool, how we piloted it in the PA hospital. So this is a test screen, so these aren't real people, okay? So how it works in the emergency department is after people get triaged, it fires like an action icon, which is in this case like a green cross, that it needs to be done. I promote that it should be done within half an hour if we are to use the tool for early recognition of signs and for early intervention. So I think that half an hour window, I believe, is a pretty good way to use it ideally. And then when you click that green cross in our electronic health record system, it fires up this assessment page and it takes you to this page where you do your risk assessment. So with this risk assessment, it's you click on those little boxes where it's like a yes, no, and it automatically scores it. Now, the beauty about having it in a digital health record is that you can create a function so that it fires up an alert. Now, let's think about the alert as a communication tool. So we use these alerts as a feature to communicate the risk, so that it also it gives those people as well who open people's charts, particularly other clinicians, because it also gives them the opportunity to control triggers for escalation and to minimize occupational violence risk too. So remembering that, you know, us nurses, we're not the only people who care for the patients. So, you know, we have medical, allied health, and other clinicians looking after the patient. So in terms of alert as well, we have a sort of, you know, let's just call it a dashboard where it indicates people who have high violence risk. So there's a pop-up alert, and while they are in the emergency department, you're also are alerted, much similar to when you're alerted if a person has allergies, for example. So I think back to the actual meat of this thing, did it work? So let's first talk about, was it used? First month is, we've had really good adoption. So we measured the percentage of patients who were assessed for occupational violence risk in the emergency department. So we've had 63%. And then this was then monitored every quarter last year. And we're finding that roughly about 2 in 3 patients were assessed for violence risk, which is, in my opinion, and also in implementation experts' opinion, is a pretty successful adoption metrics. In terms of, did it make an impact with our occupational violence incidents? We are observing, based on the data, is it has. So in our emergency department, we have our amazing behavioral management team that we locally refer to as ROVE, which stands for Response to Occupational Violence Emergencies. And the primary role for the ROVE is to support nurses who felt who might have felt like a situation is beyond their capacity to manage, and they ROVE manages people with behavioral concerns and people who have already escalated as well. And they keep a database, and we're tracking that database in terms of whether incidents occurred. So before we had a tool, 43% of the cases that they attend were for OV incidents, and we're finding that over time it's reduced. So based on this data, we can say that the risk assessment tool has done its job. In terms of the number of verbal or physical occupational violence incidents that have been reported to our risk man, as you can see here, you can see it gradually coming down as well, which again is a really good result. Now, I think it is also important to measure success not only by how much it's used or whether it's improved our incidence, but I think we should also see it from a perspective, did it actually improve the way we manage patients? So one of the key metrics in terms of looking at how we respond to occupational violence is we generally look at restrictive interventions. Now, with our restrictive interventions, we can't quite see a pattern with it, whether it's reduced or whether it's increased, because as you can see, it fluctuates quite a bit. And there are varying factors of that. It just depends on how many people get in the emergency department, and it would also very much depend on what they are before they come to hospital. So we can't make a definite call on this one if the risk assessment has sort of improved the way we manage occupational violence. But what we do know so far anyway, that it has reduced our incidence. And from a staff safety perspective, I think that's a win. Would you all agree? That's good, that's good. Okay, so what made it work? In terms of what made it work, I think I'd like to summarize the point that 3 key factors made it work. So the first one is attitudes and appetite for change. And it's not just about the appetite for change for the whole organization, but us nurses as individuals, how we see the risk assessment and how desperate and how much we want solutions for occupational violence. The second one is collaboration and consultation. It's really important to undertake work like this, because if you want to get it right, you want different perspectives on board, and that also includes consumer perspectives as well. And implementing it, particularly the way we did it at the PA, where we had to put it in the statewide electronic health record, is a massive undertaking that I myself would not be able to undertake. So the point that I'd like to make is having more people support you and taking them on a journey so that they can co-own the risk assessment tool as well. And the last important bit is a team-based therapeutic plan or a team-based approach. And the reason why I make this a point is that risk assessment tools really are only as good as the interventions that come with it. And so when you identify a risk, when you identify a problem, you should have a solution. And so this is the point that I'm making about having a team-based approach. So let's have a look at the attitudes. So I've put unhelpful versus helpful attitudes side by side. And I'd like you to just sort of quickly read over that and reflect in your own practice as well. And I'll take you through each point. So, but I'll give you a bit of a moment to reflect on unhelpful attitudes versus helpful attitudes. Okay, so let's start with a tick and flick. So risk assessment tools, you often reduce it to tick and flick. And I actually believe that the moment you do that you reduce something as tick and flick, you already subscribe to the fact that the tool isn't going to work. But if you restructure your thinking and see it that you're going to use it to better engage with patients, that's definitely a start. Now, the next one that I often hear, it's something I already do anyway. Now, focusing on the I, it's something that you do, but do other people actually do it? And when we were doing this qualitative research in terms of scoping on how the tool could work, a dominant theme, particularly from more experienced nurses, is that it actually helps others who might not be as experienced at picking up early warning signs. And so as soon as you say it's something you already do anyway, and you don't need to be told, think of others who might not have that level of knowledge as you do. Now, another one is it's another bloody form. How many more forms do I have to do in my work? Now, we purposefully designed the risk assessment tool to be nice and quick, to be nice and brief, so that it makes it easier for you end users, nurses, to use this tool. So the way we can reframe this unhelpful attitude is, 5 seconds to do the form could actually save you 20 to 30 minutes down the tracks from escalation and having to restrain someone. Okay, this one, and I'm really cautious about the alert actually, and about the stigmatizing attitudes to what we would consider already vulnerable people, particularly our mental health patients. And there is some data backing to this, particularly in the cohorts at the PA that we were studying, that people who have mental illness, they are overrepresented in the population that we are studying. And so, as I mentioned, I'm cautious about stigmatizing attitudes and the stereotype. But the one way that we could prevent the tool being misused, being as a stigmatizing tool, is that we think about it, that alerts can enable us to communicate the risk to other clinicians so they too can better engage with the patient, not just us. Now, let's always think about that we're using the tool to explore people's triggers and how we can help minimize those triggers and how we can help find solutions for those triggers. So let's always remember that. So the next point that I'd like to talk about is collaboration and consultation. The other thing too, please don't tell people that I have them here, because I haven't asked their permission that I could use it for my QNMU talk. Actually, I was a bit naughty. Oh my God, this is recorded too. Okay, now, in terms of, and the reason why I show, I like showing these photos is that I'm truly privileged and I'm really proud to be working in such environments where the team is sort of really supportive of innovation and supportive of doing something different. And I could not have done this work without their inputs. And I'd like to sort of unpack what collaboration means to me, actually, but particularly in the context of this work, that collaboration means that knowing and seeking out the people who can help you achieve your goal. So I was looking for people who can help me shape and implement this risk assessment tool. And as I mentioned earlier, it is really crucial that you take them along with you. So it becomes their goal as well. And I definitely had a lot of help, particularly around the digitalization of it. So had heaps of help from Office of the Chief Clinical Information Officer, eHealth Queensland, from our data and analytics team, from our security team, the research team even, and now I'm working with our ProbED team. So it's a team within Queensland Health that is now developing tools and planning so that that risk assessment tool that I just showed to you will be available to other Queensland Health emergency departments. And we're really gaining traction in that one. The other exciting thing that I'd like to share, actually, if you look at the photo on your right-hand side when where a nurse is pointing at a screen. Now, the risk assessment tool is that information is turned into a dashboard. So in essence, what this they programmed this dashboard so that it shows a security team where high risk areas are. And the purpose of that is that so that they can round those areas that nurses might need assistance, and also to build that rapport early with patients. Now, it's still in its early days. I think it's only been a week or two, and the system is still a bit clunky. So we're still to find out how well this dashboard works. But what I'm absolutely trying to say here is that we've taken advantage of this risk assessment tool and turn it into something that's also useful for other key players of occupational violence, which is our security team and our behavioural management team. Okay, the last part of what makes it work is having a team-based approach. And what does that look like? All right. So this is just a really rough management plan. And the purpose of me showing this to you is, once again, to reiterate that risk assessment tools is only as good as the interventions that come with it. And it's important for organizations. For example, you might want to use this tool. It's important for you and your team to have a process on how you manage occupational violence risk. Because if we do not have the process, we are going to go back to square one of risk assessment tools being tick and flick and being misused as stigmatizing tools, once again, for people who are already vulnerable. So as you can see here, I put you, us nurses, that it's important for us to think about our own safety first. So we can't be looking after people well properly if we ourselves are unsafe. And also the patient part, we need to think about what it means for them and what we can offer them when they pose a risk of escalation. And also the last point is, what are we doing with our environments? What sort of triggers in the environments that we can help minimize or we can help control? So just some of the pearls for you. And my attempt, my tip to you would be, I think, in terms of communication and de-escalation skills, it comes handy with implementing a risk assessment tool. Now, also, I'd like to give a disclaimer that, I've shown you that risk assessment tools work, and you might feel excited, you might feel optimistic. Yes, please do, but also think that risk assessment tool is just one part of a large solution for occupational violence. It's one component, same as your education and training about communication and de-escalation. So these are the things that need to be packaged together for things to work really well. And also, always have backup. So in terms of high risk ones, we are lucky at the PA hospital in our emergency department that we have a behavioural management team, and we also have in-house security. But in other places who might not have a behavioural management team, know who your backups are. All right, and that was really a lot quicker than I thought. And so there you have it. So that's the risk assessment tool. And these are the 3 key factors that make it work. So once again, it's really important that we have a good attitude and appetite for change when we use these risk assessment tools, so we can use them properly. Collaboration is key. Having a really good team that backs this initiative, and also a team-based approach, so that we can have a good management plan when we identify violence risk. So yeah, thank you.
Thank you, CJ. That was so good. It was excellent to hear. We're going to open the floor now to questions. So if anyone had any questions, you can raise your hand and I will get to each person one at a time. I've just noted that QNMU Workplace Health and Safety official James Gilbert has made a comment in the chat. James, did you want to speak to that? If you're still online?
I didn't, but I will. No, that's a great tool, CJ. That's really good work, and that will assist in your employer meeting their obligations. Well, they currently exist now, but they're going to be employers are going to be scrutinised a bit more around this sort of thing when a code of practice that's just been developed comes into place on the 1st of April. And you're right, the tool is merely a tool for identification, and an employer has to then provide direction and assistance in implementing controls. So you're right, it is part of a wider thing. So it was great work. Thank you very much.
Yeah, thanks, James. That's really good to hear. And I think another point that's I would like to let the audience know as well is that if we're going to talk about, and James, thanks for reminding me to talk about this one, in terms of the work health safety obligations, it is actually an employer's responsibility to communicate risks to staff. And in terms of under the banner of reasonably practicable, alert system is the most practicable way to do that. However, as I mentioned earlier, it's really important that we do not misuse this tool, but we also have a clear governance on, for example, removing historical alerts when they no longer apply. So that's another thing that organizations might want to think about when they do use this tool in their clinical areas too.
So I'm just looking through the participants and I can't see anyone that has their hands up for any questions.
I just see people's comments. So thank you very much, everyone. I'm glad that the tool is well received. So thank you very much.
We've just also added in here that if anyone wants to pop their questions into the chat, so we might just give it a couple of more minutes just to see if anyone wanted to pop any questions into the chat there. So we do have a question that's come through now from Jo McInnes, who has said she works in ED. Would this be done on arrival at triage or when doing your initial patient assessment?
That is an excellent point. So the reason why we developed this so that it's nice and quick, so that triage nurses would be able to do it on arrival. However, we realize that it's very much dependent on the workload of the triage nurse. Hence, we have made it that we've given a timeline that within half an hour of people arriving in emergency department. So it has that. We've designed it so that it has the flexibility for triage nurses to do it, or the treating, the nurse allocated to the patient in the emergency department. So what's happening to my Zoom?
Sorry, CJ, that was me. I just stopped screen sharing so that we could see your beautiful face.
Oh, okay, sorry. I was like, oh, what happened?
So I had a question as well, CJ. So it's my understanding that this is going to be rolled out to EDs that use FirstNet.
At the moment, it is primarily programmed in FirstNet, and for emergency departments that use EDIS within Queensland Health, a solution is being worked out at the moment anyway.
Yeah, that's fantastic. And when do you think our nurses may begin seeing that in their emergency departments?
I can't say for sure when it's going to be, because as you guys know, change in terms of this scale. And like I said, we have to be very cautious about implementing a risk assessment tool without an actual process. And so it could take a bit of time, but it should not stop you from using the risk assessment tool, although not in your clinical process, like in EDIS or FirstNet. It's something that you can use as an individual as well, something to keep in mind.
So we do have another question in the chat from Peter Fahey. So Peter, I hope I'm getting the essence of your question right, but I think what Peter is saying is, can this assessment be used as a live document that can change over time during the patient's admission as their condition changes?
Yeah, Peter, thanks for that question. Yes, it can be. So remember that the tool captures static factors. So your static factors are the ones that don't generally change. So that's the historical factors, their history, and the nature of the clinical presentation. So it's the behaviors that are really key to change. So I don't know if you guys recall that assault cycle or that escalation thing. So it's the behaviors that we need to keep an eye on if we are going to use this tool as a dynamic risk assessment in inpatient. In terms of inpatient settings, we haven't tested it just yet. So if you would like to use this tool in your inpatient settings, please do, and let me know how it works and how you go. I would love for people to test this tool. And like I said, it's free. You don't need my permission or anything like that.
So we have a question from Rebecca Elmore. She's just asked, CJ, can other sites turn their risk assessment on in IMR, or do they need to wait for it to be implemented into the program?
Thanks, Beck. I'll work you back at the PA. Thanks for going through our talk. Beck, at the moment is that if there is capacity in your emergency at the moment to implement this risk assessment, there's no reason for your ED to wait for the statewide rollouts. I think you should be, I don't know who looks after your IMR, but be in touch with the personnel who do and see what you can do. Because I mean, like, as I said, if a process is already in place, and you have capacity to roll this tool out, please do. Yeah, use it. The sooner the better.
Couldn't agree more, CJ. So we've just had a question. Whereabouts can our members get the risk assessment tool from? Because we will put a link in the follow-up email so that members are able to access that.
Sure. We can put in a link to the publication, which is open access, as well as the publication as to how we implemented it. So you can get some pointers into what resources that you need to implement it.
So we've just had, yes, thank you.
Oh, yeah.
We've just had another question through from Kim Ramsdale. So Kim has asked, do you collect data from this, e.g. looking at trends?
Yes, thanks, Kim. That was something that I forgot to put up. Maybe I should have put up how people are scoring. So generally speaking, 1 in 10 people who come into the emergency departments have a high risk score. And I think if I do so 1 in 10, I think maybe 20% were moderate risk, but I'm pretty sure on a 1 in 10 is a high risk.
It would be also interesting to see what that statistic is like when we look at the inpatient wards as well.
Yeah, absolutely. And the other work moving forward as well is that how many of this, now that we're using the tool, how many of these risks convert into incidents would be an interesting metric or outcome to look at. Kim, did I answer
Absolutely.
your question?
She said yes.
Okay.
She did a thumbs up. So
Oh yeah, awesome.
Actually, I'd also like to ask, do you report those trends and that data anywhere? I know you would be involved in the statewide occupational violence group. Would that be right, CJ?
Yeah, so in terms of the rollouts, my role is advisory at the moment, so not really active. How they're going to use the data in terms of publishing externally or being transparent, I don't have very much control over that.
Mhm.
But I think it would be good because, I mean, now that we capture accurately anyway the risks in the emergency departments, we can use this to substantiate, for example, like business cases for more security, more nurses, for example, or some sort of funding so that we can be upskilled in terms of communication and de-escalation.
So we've just had another question come through, CJ, which is when the patient is transferred from ED to the ward, is there an alert system for the ward staff?
Another excellent question. So because at the moment it's very much a pilot work, even it's only even it's been a year of us using it, we've turned off that alert to inpatients. And once again, it comes to the maturity of inpatient wards in terms of managing this type of violence. But that's not to say that we can't have the alerts. Like, yes, we can. But once again, we need to, this visibility of alerts, this communication of alerts, needs to go to places where they have the capacity to manage occupational violence risk. But sorry, so the short answer is yes, we can do that.
So I can't see any more questions coming through. I just wanted to thank everyone for coming along this evening, and particularly CJ, thank you very much for presenting this to us, and thank you for all your hard work. It is really amazing.
Thank
and
you.
we're
Thank
so
you.
appreciative.